So today, as part of the social EM series, I'm going to be talking about how we can serve our unhoused ER patients, a really important demographic, both at Kings County and downstate. And the title is It Wasn't Just One Thing. Okay, so let's start off with a case. This is actually a patient I had on Thursday at downstate. So a 48-year-old woman with a history of lung cancer, status post-lobectomy 6 months ago in an outside hospital, interstitial lung disease, comes in with 2 days of a cough, fever, and shortness of breath. She comes in, she's febrile, she's tachycardic, and satting 100% on 3 liters of nasal cannula, which she has with her. That's her home requirement ever since her diagnosis of lung cancer. She also has with her a bag full of her clothes, folders full of medical records, and some food items with her. When you ask her if she's had any sick contacts, she says, yes, plenty. Everyone at the place I'm staying at now has the flu. You ask her a little more about how long she's been there, and she says that she's been at the shelter for the past 5 months. Since her lobectomy, she lost the ability to keep her job, which then led to the loss of her medical insurance coverage, and she fell behind on her medical bills, which then led to her not being able to afford rent in her apartment. She had her own apartment before her diagnosis. Without any family nearby, she had been in the shelter ever since. So at Kings County and SUNY Downstate, patients who are experiencing homelessness make up a really important and significant part of our demographic. It's important to note that not all patients who are homeless look the same way. Some who are chronically homeless, you may be able to kind of gather by their disheveled appearance or the fact that they have all their items that they own with them, but sometimes they look just like any other patient. And while we may feel confident that we can address the medical needs of these patients, the lack of secure housing is a need that feels a lot more challenging to fix. So for this patient, she ended up being diagnosed with pneumonia, bacterial pneumonia, community-acquired. And we considered things like PSI and CURB-65 score for whether or not she needed to be admitted or she could be treated outpatient. She's relatively young. Based on her history of lung cancer, we decided to admit her for treatment of this. But we also considered her housing status, how well she would, how exposed she would be to the other people in the shelter who everyone has the flu now, so she'd be exposed, how much rest she'd be able to get, adequate nutritious food and water. And although this isn't part of the concrete scoring systems that we use, it should be something that we consider. And I think we do a really good job of that here. So sadness, opposite of joy. I know many of you have the shared experience of feeling frustrated, helpless, and oftentimes I think the feeling is just sadness when you meet a patient and hear about their circumstances being homeless, and especially when it feels like we can't do more to support them in these needs. Lack of affordable housing and housing insecurity, secondary to systemic oppression, feels like a really big battle in just one patient interaction out of the many patients you see on a single shift. But I think by familiarizing ourselves with the system that our patients have to navigate, especially locally, like the patients that we're seeing here, screening patients for housing insecurity and then connecting them to appropriate resources if we can is a start for us to kind of feel less hopeless in these cases. So we'll be discussing some of that today. Here's just my quick outline. So we technically define homelessness as anyone who lacks a fixed and regular nighttime residence. So this can include various types of situations. It can be people who live in temporary shelters or transitional housing. It also includes people who choose not to stay in temporary shelters or housing, which I think we have a large group of patients as that as well, who choose to take refuge on the street, essentially, in the subways in New York City, often under the bridges. These patients are at highest risk of poor outcomes as they're facing the natural elements like Colin described, when we have extreme weather patterns and are at constant risk of being robbed, assaulted, or arrested. You can have like patients come in, you hear that for med refill, oftentimes they say like all my meds were stolen, which sounds crazy, but you know, when you're out living on the corner, that's something that actually does happen. Most people experience homelessness transiently, but some chronically. And the people who experience it chronically often have co-occurring mental health issues and substance issues as well. But all types of homelessness and even housing instability are at risk of poor health outcomes. So while we tend to think of homelessness as something that impacts someone as an individual experience, it is important to consider the multi-level importance of secure housing. And thank you to Dr. Orkachea for introducing this model to me. So initially, I was thinking about secure housing in the sense of the Maslow's hierarchy of needs, where at your basic needs, you need warmth, safety, and rest as a fundamental basis in order to achieve like ultimate enlightenment as a human being. But it's the importance of secure housing actually reaches multiple levels. So on an individual level, kind of what we talked about, having stable housing allows you to kind of be able to meet your goals, be able to grow as a human being. On an interpersonal level, stable housing allows for positive relationships with other people, healthy family dynamics, and also just social connections that can improve things like loneliness and isolation. Then on a community level, secure housing creates safety and better public health resources and healthcare as well. And then importantly, on a policy level, which ultimately kind of trickles down to why a lot of people are in the situations they're in, there are structural factors such as zoning laws and land use regulation that impacts the availability of affordable housing for people. So what are the reasons that lead to homelessness? The name of my talk, It Wasn't Just One Thing, is based on a study, that was the name of the study, by Dr. Kelly Doran. Some of you may be familiar with her. She's an ER attending at NYU, and she leads the Health Housing Lab, and they do a lot of research in this area. Her team did qualitative interviews with ER patients at Bellevue who had become homeless just within the past 6 months to kind of understand their path to that situation and what led them there. And some of the common themes they found, while each had individual unique stories, is that job loss was the most common contributor that kind of set someone on this path. In addition to that, change in family status, not being able to stay with your family anymore, not having friends that you can live with for longer periods of time, physical health problems, things especially that cause someone to be disabled, like strokes, accidents, lead to job loss as well. Mental health and substance use issues were also a common theme in that. However, underlying all of this, of course, is the lack of affordable housing. So you may recognize this man. This is Jimmy McMillan, who was the head of the Rent is Too Damn High party, which is a real party, a single issue political party based in Flatbush originally. He was actually nominated for mayor in New York in 2005 and 2009, and then governor and senator in 2010. He did not win, but he made a very true and important point about the rent being high. He kind of, you can read his Wikipedia about his later life, but the Rent is Too Damn High party was like a real thing, yeah. He changed the TOO to the number 2 because it was like too long on the to be on the ballot, but anyways. So we all feel the pain of rent going up every year. You probably got an email from your landlord with your new lease agreement where the rent is like, 3% higher than it was last year, and you just try to convince them to keep it the same. So we all feel this pain. This graph shows the median asking rent for an apartment rental in each borough as it's changed since 2019. Brooklyn is on the green line. So prices continue to go up as more people move into these highly sought out areas due to gentrification and unchecked rent regulation. People look for affordable housing options, which are in high demand, but with little supply, and lack of funding to build more affordable housing options. A little bit about the history behind kind of the legal right to shelter. So this wasn't until 1979 that a Supreme Court case, Callahan versus Kerry. So Kerry was the governor at that time, and basically like this like young new lawyer decided on behalf of 3 homeless men, one of which is Callahan, to file this Supreme Court case against the state for the legal right to shelter. These men basically said that there was like multiple occurrences where they weren't given emergency shelter when they requested it. And so that's 1979 was kind of when more shelters, being in a shelter became more common because it was an actual legal right. Much like other basic human rights, it wasn't until later, because this was actually just for men, homeless men, it wasn't until later that 2 other cases followed to expand this to women and families. Over the years, the number of homeless people in New York, this is specific to New York City, has steadily risen. This is due to cuts in federal housing assistance funding. In the 90s, there was the recession. Then you had the Giuliani era, which is in the late 90s, which under his era, there was a lot of like punitive policies for the unhoused. And the biggest rise between 2002 and 2013 was under the Bloomberg administration, where he removed a lot of permanent housing assistance programs and rent subsidy programs. The 2021 dip is because it was COVID, so obviously there was no way to really like provide a census, shelters were closed. This is when like a lot of people who are homeless were like in the hotels at that time. So that's why the data there is a little off. So in much of medicine, we struggle to kind of find ways to help people who have diseases that have no known cure. So things like COPD and Alzheimer's disease or AIDS. But for homelessness, there's been a lot of research and evidence to show that there is a primary cure, and that is affordable, accessible housing. A lot of studies have shown that not only does this reduce homelessness, it also is less expensive than building more shelters. So the Coalition for the Homeless, which is an advocacy and direct support organization, actually that Colin mentioned too, where they do like the Code Blue. They are an amazing advocacy program actually funded out of that initial Supreme Court case. And they outline kind of these 3 steps that lead someone who's experiencing homelessness to eventually coming out of it. So the first step for someone who has no secure shelter is to stabilize them through temporary shelters. So those are like the shelters that most of our patients are staying in now. I think that like, you know, it's kind of when we meet a patient who we know is in a shelter, we can kind of imagine in our mind what it's like for them there. But kind of even I feel like I wasn't familiar with what kind of services they would actually get in the shelter. But the idea is that at the shelter, they have a case manager. Every person who's in a temporary shelter has an assigned case manager or social worker. That person works with that individual to try to secure them a level of permanent housing, because permanent housing is really what's been shown to keep somebody out of the shelters. There's different types of permanent housing. The ones I've listed here are specific to New York City. They're in other states as well, but this is kind of like something that we found like locally. So for public housing, these are housing units that are owned by the government, so owned by the state. They're typically in buildings that are like close together with one another, and folks who qualify for public housing usually pay around 30% of their income to stay there. Then you have housing vouchers, or also called like Section 8 housing, and that's housing that can be any apartment. It's not government owned. These can be like privately owned apartments that are qualify as Section 8 housing, and folks who stay in these will get an actual voucher that also usually covers around 30% of their income towards the rent. And then there's permanent supportive housing, which is for people who have kind of complex barriers to the first 2 types of housing because they have things like mental health, substance use issues. And so permanent supportive housing has a lot of like wraparound services for these patients. And so that can be really helpful as well. Medical respite is another form of permanent housing that provides care for patients who are too sick to be living in the transitional shelter. So a lot of times these patients are patients with metastatic cancer diagnosis. I had a patient at Kings County who was coming from a medical respite center, and they provide medical care for them as well. And then the ultimate goal is to when somebody is in permanent housing is to also provide wraparound assistance programs, whether that's in the form of helping with finding employment, legal rights, so that they can, hi stats, food resources, and things like that. So ultimately, you know, based on what you're seeing here and based on what's actually been shown to help people who are homeless, you know, when you see a patient, obviously, it's important to know that this is kind of their context, but ultimately what we need to do is to address the housing affordability gap. And that's down to kind of the federal, state, and even city governments to increase investments in affordable housing. Strengthening rent regulation laws would also help preserve some of those affordable housing options and protect tenants as well. Just to give you some context, like Esteban says, I think it's important to kind of be up to date with some of the recent politics. During the last administration, or during the last Trump administration, funding for the U.S. Department of Housing and Urban Developments was cut by 20%, which funds everything listed on this page. And so we kind of have to keep in mind moving forward that the safety and security of our patients who are with housing instability is definitely at severe threat. Okay. So you may have noticed in the past year or so that there's been an influx of patients who are brought into our ER with no clear reason of being brought there. Sometimes the triage note says like patient was sleeping in the subway or patient was sleeping in the park. Sometimes there's like a tox component or a substance component. Sometimes there's a psychiatric illness component, but sometimes not. Like I had a patient literally, it was just he was sleeping in the subway and was brought into the ER. When you ask the patient why, they're also equally unsure why they're in the ER. They're like, oh, I was just taking a nap. Like it was really nice. I had one patient say it was a sunny day and I was enjoying the sun and I took a nap and now I'm here. Immediate discharge, but so he go back to his nice nap. But basically, this comes from in 2022, Mayor Adams announced a plan where this is from the nyc.gov website, where his plan, in his words, was to provide care for individuals suffering from untreated severe mental illness across New York City. But what that was a directive that granted New York City police to, at their discretion, identify and then forcibly remove people who to them appeared mentally ill or by definition on the document of this was unable to meet their basic needs, and then involuntarily transport them to hospitals. This didn't come with any like meaningful expansion of programming or housing for people coping with either of these issues, mental health illness or homelessness. So it really like instead meant this, which is that they're just hospitalizing people who may have one of these two things. So this just all goes to say that we are on the ER, are on the kind of receiving side of this, and we know that this is no real lasting solution for many of these people, and rather just criminalization of them. So what can we do as ER docs? My new favorite show, Pit. So screening is very important. It's often that patients who are experiencing housing insecurity or homelessness kind of don't fit the look that maybe you would expect. And so there are some questions that you can ask when you're asking a patient, just to kind of get an idea of what their life is like when they leave here or before they came here, which could contribute to what they're experiencing from the medical standpoint. These are some questions you can start with, you know, because obviously this is someone you just met. It's part of like why I love emergency medicine is like that challenge of having to establish trust within like 5 seconds of talking to someone, because it's kind of invasive to be like, where do you live? You know, so, or, you know, have you ever been homeless before? You know, you don't want a patient to feel like you're judging them or anything like that. So it can be tough to kind of initiate this conversation, but I think there's some ways that we can kind of easily or naturally incorporate that into when you're building rapport with a patient. Sometimes I say like, oh, where are you staying right now? Have you ever felt like you had like nowhere to stay for the night? Things like that. Sometimes these questions, where I feel like I've asked like, where do you live right now? Patients will be like, I live at 255 Sterling Place. I'm like, okay, I'm not sure if that's the address of the shelter or, you know, where that is. So But screening is important. So try to, if you can, incorporate some sort of question so that you can kind of assess whether or not someone is housing insecure. These are two questions that are from like the VA's official screening guidelines. In the past 2 months, have you been living in stable housing that you own, rent, or stay in as a part of a household? Obviously, very, very formal questioning, but kind of gets to the gist of like, do you have a safe place to stay at night? So you can try those as well. The second thing we can do actively is documentation. So as we know, people who are homeless have a higher morbidity and mortality, which are coupled with actually more frequent and costly hospital stays. So some of the patients that we know at Kings County very, very, very well, you know, are experiencing homelessness. And that, you know, as much as we love caring for them, like all patients, it comes with a really high hospital cost. Every single visit that that person comes for is billed somewhere, even if they're not paying for that hospital visit. And when ultimately at the core of why they're there is because they are housing insecure. However, right now we're not really capturing that data. So someone could be coming in every day for chest pain, just as a hypothetical example, but really they're experiencing, you know, something that is, the reason they're there is something way beyond that, but we're not documenting that, right, anytime they come. So the ICD-10-Z codes were implemented in 2016 to identify these types of social complexities, some of which are listed here. And being able to use these codes consistently could help us identify patients who are at risk of poor health outcomes. And from a population health perspective, can be used to quantify a specific community's needs or prompt certain research or policy that can better address these disparities. The problem right now is that from studies on these Z codes is that they're very low, there's very low utilization. So, you know, when you're discharging someone, you don't really think about putting these in. And oftentimes from what the studies on the Z codes have shown is that physicians feel that when they document this, they feel like they weren't really able to intervene for the patient on this issue. But documenting it is really important. Okay, so the next part, I just want to go through a little bit like understanding the actual system that our patients are navigating. How does one get into a shelter? How long can they stay there? Can they switch shelters? Things that our patients often ask us, and we consult social work, which we should, but I think it's also just information that we should know. So I put together some FAQs that some of questions that patients might bring up. And a lot of this information I got from Ms. Brown from social work here at Kings County, provided a lot of really helpful information for this. So a patient comes and they say, I'm newly homeless. I've never been in a shelter before. I need a place to stay. So if somebody has never been within the shelter system ever before, they are to go to the men's intake shelter. You've probably heard that because social work will tell you on the phone that's what they need. The men's intake shelter is near Bellevue. It's in Manhattan. Oftentimes these patients come, you know, if it's like in the evening, what I can do, I think that is helpful, is to like print Google directions for people. Sometimes they'll ask you to do that. I think that can be really helpful because it's not like a clear shot from Kings County. So you can just print out the subway directions, bus directions, and give it to them. If that's for like individual men and women, those are the two locations. Families with minor children and families with children, and then people who are newly arrived to the U.S., there's different locations. But if you've never been in the system before, you do have to go to the intake, which is open 24/7, so that they can register you into the system and be placed in a shelter. I've seen like through various online resources, and Ms. Brown said as well, the intake shelter, although sometimes I feel like when I send someone there, I'm like, I don't even know what's going to happen when they go there, like, are they even going to have a place to stay tonight? If they go to the intake shelter, they will be like in a shelter that night. Like they will give them a place to stay. They won't like, you know, push them away. So I know it feels like you're just sending, especially because it's like in Manhattan. For some reason, I'm like, good luck, go to Bellevue intake shelter. Like they will be assigned a place there. So they say, I live in a shelter, but I want to change shelters because my shelter is unsafe. It's not clean. I don't like it. I want to transfer, which all those things are very possible. A lot of look more into that. But basically, like a lot of the shelters are totally overpacked and a lot of violence happens there as well. They're really understaffed usually. So some people want to change their shelter. So this can happen, but it's a process that needs to happen from the patient's originally assigned shelter. This can get really tough when the patient says, well, somebody beat me up at my shelter. You have to tell them to go back there. But unfortunately, that's really the only way that they can transfer. So as per social work, they can come talk to the patient and give them that information as well, but that needs to happen. Basically, the patient has to fill out like a formal form, submit it to the Department of Housing, and they need to approve it for them to be transferred. And if they don't approve it, unfortunately, they still have to stay at their own shelter. And oftentimes in those cases, that's what really prompts people to leave the shelter system for that time and live on the street. Am I going to lose my bed? So the reason that patients bring this up is because often shelters have curfews, usually around 10 to 11 p.m., where people have to return to the shelter by that time, or their bed gets like given away to somebody else there. So that's why you see people kind of with their bags, because if they lose their bed, then they have to figure out something else. So things you can do is you can offer to call the shelter to make sure they're aware of the patient's medical visit and say they might be here past 10 or 11 p.m. If they're going to be admitted, that's also something helpful to be able to call the shelter to do that as well. Sometimes as well, if it's like late at night, I'll offer patients like transportation if their insurance allows, if they're near the curfew time, because curfew can be something that's a source of stress for a lot of people who are living in temporary shelters. So the Coalition for the Homeless is like an amazing resource that I learned so much from making this presentation. So if you want to kind of find out more about the local New York City shelter system and some of the stuff we talked about there, you can go there. Addressing immediate care. So this is something that, I feel like we do on a daily basis at Kings County. We really our wraparound service. I think for patients who are homeless, making sure that they have some of these, if we can be like feels like a Band-Aid, and honestly it is, but we do have some resources to be able to help them. Like if they can offer a meal, you can ask social work if they have extra clothing to give them. And then for patients who are in shelters but have like chronic wounds, sometimes I will just throw like 10 gauzes at them. Yusuf's not here. Just give them some gauze, give them some tape, just give them some gloves, right? They're doing their wound care in a shelter of like 100 people. So as much as you can give them so they don't have to make those trips or go buy more, it's something that we can do. And then 311, in other areas of the country and upstate, it's like 211 is for things like shelter, food, that types of resources. But in New York City, like 311 does everything. They are a great resource. I called them when my car was lost. They helped me, but they also have resources for all types of things, like where are the closest food banks, where are the closest domestic violence shelters, and things like that. So you can let patients know about that if they don't know about that already. And lastly, just to clarify a little bit about like our teamwork with social work. So I think sometimes there's a little bit of like confusion, and maybe we may feel some resistance because social work, we'll call them and say the patient has an issue with their shelter, and then social work is like, well, I can't do anything about that. And then the conversation, it's like, well, please still come see the patient. Like that can be a little bit of like a confusing conversation. So I talked to Ms. Brown to kind of clarify that. And basically the answer she gave was that no matter what, if, a patient has a concern about their shelter, going to a shelter, changing their shelter, social work can come and do an assessment of the patient, right? That's not something that we're trained to do, to like fully assess the safety of a patient and their housing situation. We can know these facts. Like, for example, you have to be at your original shelter to transfer, but patients who are experiencing homelessness should be reassessed. Like, I think it's helpful when you look at a patient's notes, right? When they come in, like reading the social work notes, I think that's like really helpful. And that only happens if you're consulting them. So even if you experience like a little bit of that pushback, like just consult social work, but try when you do the consult to have a specific question, just like all services tell us, have a specific question in the consult. So instead of just like patient is homeless or like, transfer shelter is like patient would like, is feeling uneasy. Is this a safe discharge? Can you provide the patient with some more information? I think those are all like, specific things that you can ask social work to talk to them about. Ms. Brown wanted me to share like these kinds of things about like specifically what they can and can't do while a patient is in our ER. So what they can do, like I said, providing answers to these questions. They can provide clothing when we have it available. They can assess if a patient is an unsafe discharge. So let's say you have a patient who, I had a patient who was like wheelchair bound, like had some like new dementia, confusion, and was living in a shelter. And she assessed him and said, I don't think he's okay to go to the shelter. And then he, got admitted for different type of placement. So that kind of thing. Or if a patient requests to talk to social work, that is a totally fair reason to have them come. And maybe there's something that the patient feels comfortable talking to social work about, but not you, and that's fine too. What they can't do, so they cannot facilitate shelter transfer from the ER. They will have to direct the patient back to their original. And they also can't facilitate permanent housing placement because that's the role of the shelter caseworker. And then lastly, if you are interested in kind of community ground level work, there are mutual aid organizations all throughout the city and in Brooklyn. The probably most local one for us is Crown Heights Mutual Aid that does a lot of food giveaways, clothing drives, and direct help for homeless population. So you can get connected with them. A lot of them have like Instagram you can get connected with. All right, lastly, just a little video. See if this works. A turtle flopping. Yay! And this could be us. Yay. Thank you, everyone.